always be aware so that we are not caught napping. So, welcome you. I am Mehiga Inabudoso. I practice OBGYN at the University of Benin Teaching Hospital, and I major mainly in fetal maternal medicine and high-risk pregnancy, and also obstetric ultrasound. I coordinate the Benin Fetal Diagnostic and Ultrasound Center. This center has been the forefront of ultrasound training in West Africa and has organized the fetal medicine and OBGYN ultrasound workshop in Benin since 2014. It does this in collaboration with the International Society for Ultrasound in Obstetrics and Gynecology, ISOG. We've had an unbroken succession of workshops since 2014, but in 2020 we had to put this off because of the pandemic, the COVID-19. So after a lot of discussions and negotiations, we felt that we should put up this weekly webinars, to continue to expand the frontiers of training and learning in our shows. This webinar is done in collaboration with the Obstetrics and Gynecology Department of the University of Benin Teaching Hospital. It's one of the foremost training institutions for OBGYN training in West Africa, and it operates a fully subspecialized training and service delivery system in OBGYN. It also has a master's in reproductive health and also a PhD in reproductive health with the Center of Excellence in Reproductive Health Innovation, which is a World Bank project of the University of Benin. As part of our plans, we have the weekly webinars. We've been on for over a month now. And then we take relevant OBGYN ultrasound-based topics, general ultrasound, things that have to do with COVID, Doppler, transvaginal, and we bring in experts from different parts of the world to assist us in giving these programs. Today is not an exception. The topic that we have for today is a very important one: fetal Doppler velocimetry. So we had it, and then we took a different section of it. As you know, these are major topics. And for those who used to go to India and many parts of the world to learn, you spend sometimes a month, there are even diploma courses of about 6 months in Doppler velocimetry. So we can't take everything at a go. However, we take small bites, making us the main aim being that we understand what is being done, understand Dopplers, we know how to interpret them, and then also we learn how to do them. But before we start today, I want to quickly also tell us about some other programs, the ISOG program. ISOG is International Society for OBGYN and Ultrasound. So it plans a virtual World Congress. And you can always go to their website to register. I'm aware that very many Nigerians have registered. This also gives us advantages of being a member. And once you are a member, you can have access to related topics. So we encourage each and every one of us to try and be a part of some of these programs. Also, before we continue, I wish to just give us an idea of our own website. This is our website. We'll still display it at the end of today's program. This website is of the Benin Fetal Diagnostics. Okay, let me share that again. Sorry. Okay. Sorry. Yes, please go back and rewatch whatever has gone on. So we encourage each and every one of us to try to make sure that they are a part of it all. So without much ado, I think we now move essentially to what we have today. Any further announcements, we'll take them towards the end. I don't think we're are seeing these slides now. Sorry. Okay. So let's share. Okay, good. So I think we see this slide now. Okay, we've already talked about this. So today, as I said, we have a very important program for today. And as part of what's going to happen today, we've worked on a very great innovation whereby we can actually do a live demonstration on Zoom. It's something that even the international community has been considering. They've been working hard at it to see how you can train people. And the last few days to weeks, we've been working on that. And that's part of it. We test run it and we see that it's working. And that's what we intend to do. We're going to have a live demo. And after that, we'll have a short lecture. So it's expected that today's session should take us about 1 hour, 15 minutes. So let's get ready for the ride. Permit me now to present the first presenter, or to introduce the first presenter for today. He is Dr. Shile Goshitz. For those who are in our blog, he is not new to any of us. He's a great young man. He's a pre-part 2 senior registrar at the George University Teaching Hospital. Already, he knows his path. He's majoring in OBGYN, ultrasound, and then he has attended a lot of courses on ultrasound-related issues. He has done a lot to develop himself personally, doing a lot of studies, reading, and practice. This is a young man that I can say he is a goal-getter. Right from 2014, when he first attended our program, it was not difficult to spot him. I know he loves teaching and practicing ultrasound. Immediately he was spotted then, it was easy to know that this person was going for the jugular in ultrasound. And today he's one of the leading lights of ultrasound in our country. Dr. Shile Goshit is one of those that I also give credit to for this webinar. Dr. Shile harassed me to a standstill. Let us start the webinar. We consider the cost and the time implications, but he insisted. And we are glad to say, because of that insistence, we are having this program today. Let me not talk too much and let me not waste our time. Let us now give it up for Dr. Shile Goshit from Jos, who is going to be doing something innovative, giving us a live demonstration of fetal Doppler velocimetry, more specifically, how to obtain the umbilical artery Doppler velocimetry. Dr. Shile, please, you're welcome. You can share your slide. Dr. Shile, please.
Yes, yes, sir.
Yeah, you can share your slide now and then you can start.
Okay. So, good afternoon, everyone. It's a great privilege for me to be here today. And really more so that I have many of my teachers on this platform and I have this opportunity. I'm grateful. Thank you so much, sir. We're going to be talking about the basics of umbilical artery Doppler acquisition. And if you look at the slides, you can see that the basics are highlighted, emboldened, and also acquisition. I know that we have people with different levels of experience here, so we'll try to make this as basic as possible. I'll just go through a very brief outline. This presentation is going to be very brief, and then we'll try to demonstrate the acquisition of the umbilical artery Doppler waveform. So it's important to note that Umbilical artery Doppler, or Dopplers generally, are a form of antenatal surveillance. And the aim, just like other forms of surveillance, is aimed
Dr.
at
Philip,
preventing.
please.
Yes, can you hear me?
Okay. Because I'm going through the charts now. When I was speaking, was the volume okay? Were you hearing
Yes, I could hear you.
clearly?
Yes, I could hear you clearly. I can still hear you clearly.
Okay, so I'm wondering why many people are saying the audio is poor. And let me just quickly advise people should learn that when you are going to attend a Zoom meeting, try to log in early and then you can solve the issues of your network and of your system. We are seeing now it's in the last 5 minutes that people are logging in. And based on that, you would have missed out on test running your system. And it's one of the things that we all must learn. For us, 3 o'clock is 3 o'clock. We don't add a minute. So actually, I start 2:59 and we set up the system by 2:30, 30 minutes before the time. So now I'm reading a lot, people are not hearing, people are not hearing. Where we test run it 30 minutes ago. So I think the people should also look at their system and look at their network. So I want to be sure, since you are hearing me, means everybody as well should also hear me if their network is in order. So please go on. You can return to your first slide and then you can just start from there. Sorry for the disturbance.
It's okay. Thank you, sir.
Yeah.
So part of what I was trying to say is that this presentation is going to be as practical as possible. I have some just few slides. And then one of the slides is going to be a very short video, about maybe 2 minutes, 45 seconds. And I hope we can all follow. So it's important to note that Dopplers are a form of antenatal surveillance. And like other forms of surveillance, it's aimed at preventing perinatal death and handicap or morbidity. And we all know that the aim of every pregnancy is a healthy mother and baby. And therefore, Doppler is a very useful tool, especially when we come to the management of high-risk pregnancies. In this case, umbilical artery Dopplers serve as a very important signal to tell us what exactly is happening and what further investigations or actions we may need to take. And the beauty with umbilical artery Doppler is that there are actually guidelines which are available for standardization. We would see that most of the content of this webinar or my presentation is called from presentations from the ESWOG and FMF sites that have been pace setters in ultrasound. And it's also important to note that just like Dr. Higa had stated earlier, there are abundant learning resources, as can be seen in the Benin Ultrasound Group website, again, ESWOG and FMF. So the question now is, why or how important, why is it important to check the umbilical artery? And to do that, I want us to have, this is just a slide showing the materials we could have access to. Now, I want us to look at this very short video. This video is less than 3 minutes long and is well illustrated to emphasize what happens at the fetal maternal interface, and then we could see at what point Doppler come in handy. So I'm just going to play this video, and then I want us to please
Umbilical artery Doppler measures the velocity of blood flow inside the umbilical artery. Let's examine this part of the umbilical cord. During systole, the blood flow is very fast. This depends on the fetal heart contraction. During diastole, the blood continues to move forwards towards the placenta. But this depends on the placental vascular resistance. Doppler study will examine these velocities and represent it graphically on the ultrasound monitor. In normal pregnancy, the healthy placenta has a low vascular resistance. In this graph, the highest point on the cardiac cycle is the peak systolic velocity, referred to by the letter S. And the last point on the cardiac cycle is the end diastolic velocity, referred to by the letter D. As you see, the end-diastolic velocity is high, and in this example, it's nearly 1/2 of the systolic velocity. And this is due to low vascular resistance in the healthy placenta. From these values, I mean S and D, we measure the Doppler indices. I'll talk about the indices a little bit later. But now let's see what happens if the vascular resistance increases inside the placenta. With increasing the placental vascular resistance, blood flow will slow down during diastole. On the graph, the end-diastolic flow will decrease. With more rise in placental vascular resistance, blood flow will stop completely during diastole, and it will present as absent end-diastolic flow. With more and more rise in the placenta resistance, blood will move back during diastole. On the graph, it will present as reversed end-diastolic flow.
Okay, thank you very much for paying attention during that video. So basically, just to give those of us who are not too familiar with Dopplers, just a brief overview as to the science behind Doppler acquisition. So how do we get ready for acquisition of the umbilical artery Doppler? It's important to note that we should have a machine with Doppler capabilities. This looks very elementary to state, but many times people would call to say, I'm trying to acquire a Doppler image, and it may just be that the machine may not have the capability for that. Most modern machines, however, have these capabilities at the moment. Again, it's important to get familiar with the knobology of the machine. As we go ahead, we're going to be talking about needing to zoom, needing to increase the gain, needing to put on, adjust the pulse repetition frequency, and all that. So it's important for us to understand the knobology of the machine. And one of the things we need to do is to ensure that our client is comfortable. Remember that sometimes these examinations may be part of extended exams like the biophysical profile, and you want to ensure that the client is comfortable and ready for the examination. An important point to note as we get ready for this examination is that it's important to confirm the gestational age. We know from the pathophysiology of maybe certain hypertensive disorders, we know about the waves of trophoblastic invasion, and we know that depending on the gestational age, what you expect, the level of maturation, what you expect to see at the maternal-fetal interface would differ based on the gestational age. So one of the things I want us now to look at is what are the steps in acquisition of a waveform. And this is basically a summary of recommendations from the Fetal Medicine Foundation and from the ISWOG guidelines on recommendations for Doppler acquisition. So I'll just quickly go through them and then we'll be ready to demonstrate. So we want to start by saying that first you would want to identify the area of interest, and then we would zoom into that area of interest. Remember that the area of interest in this case is the umbilical artery. Sorry, I'm getting I'm switching my video off for a few seconds so that my wonderful client here can get ready for the demonstration. Are you comfortable?
Yes.
Okay, so I can go ahead now. Okay, so back to my video on now. So the first thing we'd want to do is to zoom to the area of interest. And we would want to identify the cord. We remember that the cord is three vessels. We have two arteries and one vein. And when you look at it in cross-section, it has what some would say is a characteristic Mickey Mouse appearance. And then when we identify the cord, there was some debate at some point of whether it's to check at the middle of the cord, the fetal, or the placental end. For the sake of disambiguity, many recommendations like the ISWAP would say that a free loop of cord should be used. And then with that, we're able to narrow the color box, apply the color Doppler and narrow the box. It's also important to state that this is not mandatory. However, it could be helpful in identifying the vessel of interest. Another thing that is important to do is that we will need to adjust the velocity scale, and those are the things we're going to demonstrate. Again, since we're talking about pulse wave Doppler, we're not talking about continuous flow Doppler. With the pulse wave, we will need to apply the gate, and then we'll need to adjust the gate to ensure that it covers the vessel completely. And it's important that this point is noted, because if it doesn't cover completely, or if it goes out of the vessel, you get a lot of noise signals. And the optimal insonation is actually complete alignment with the blood flow. Again, some would ask, okay, what about, do we adjust the angle of insonation or not? That's not always, may not always be recommended, depending on the vessel you're checking, however. And then it's important to talk about the adjustment of the filter, the wall motion filter. And this helps us to eliminate the noise from the movement on the vessel walls. And we'll try to make the wall motion and filters as low as possible. And then other things to note is that it's important that we would want to get successive waveforms, maybe about 4 to 6 waveforms, less than 10. We should adjust the PRF, that's a pulse repetition frequency, accordingly. And then again, to get a good waveform, it's good sometimes to adjust the gain. So not to take too much of our time, because there's still more to do, we're going to go through this demonstrating with a wonderful client here. So I'll go through everything I've said, from making sure the client is comfortable and all that. So I'm going to stop sharing this screen and begin sharing the screen of my ultrasound machine now. Okay. So can you see the screen of my ultrasound machine?
Yes, I can. Yes, I can see it.
Okay. Okay, thank you very much. So I have my client here, and I welcomed her. You're very welcome, madam. How are you today?
I'm fine, thank you.
Okay, welcome. I'm happy to have you volunteer for this. We're very grateful.
You're welcome.
Okay, my client is she's lying down comfortably, and she's properly covered. And I would want to get her names. And since this is a demonstration, I will just enter her initials, and then initials for her first name. Madam, how old are you, please?
30.
30 years old, okay. And then this is your first pregnancy?
Yes, sir.
Okay. So she's a primary gravida. Do you remember when you saw your menstrual period last?
22nd of December 2019.
Okay, so that's the day it started, the
Yes.
22nd of December.
Yes.
Okay. So our client is about 29 weeks, 1 day of gestation. This is important to note, because when we interpret these results, it's actually the nomograms are plotted based on the gestational age. So we'll go straight. We're in Jos, so Jos is cold, so I try to ensure that the clients have gel that is warm, so that they are comfortable during the exam. Now, talking about the probe to use, I think you can see I'm using a volume probe. It doesn't have to be volume.
Philip, just a
Yes,
minute.
sir.
Now, let me encourage the people, for many who may not know how to use Zoom properly, for you to maximize this view that you have now. You already have a slideshow. Then you go and adjust so that you can only see Chile. So it's only on that basis that you enjoy it. If you are seeing multiple views of people who are in this platform, you may not be able to enjoy it. So there is a portion there whereby you view and you see only him. And based on that, you can see what he's doing and you can also see the view. So for those who are able to, I expect that they will be able to do that and enjoy it maximally. So you can go on. You have 5 more minutes.
Okay, that's okay. We'll be done before then. So basically, I'm just looking around. You can see the fetal heart, and this just to reassure the mother that her baby is doing well. And then you see the baby's heart, right?
Yes.
Okay, so we're going straight to follow the steps we talked about for our position. So if you look, you can see, I'm going to zoom in to make sure that we have the umbilical cord in the middle of the screen. And if you look closely with my arrow, you can see that we have, this is the abdomen. You see where the insertion of the umbilical cord is the fetal end. And if you come over here, you can see the placenta end. So if I put color flow, you can see where it enters the placenta. So, well, since we just want to get a free loop of cord, so we're told that the step is first, we need to zoom into the area of interest. So this is the zoom box, and you can see me zooming in, and you can see that we have two umbilical arteries and one umbilical vein. This is the characteristic Mickey Mouse appearance. And then the next step we mentioned, you can see fetal movements, is to apply the color Doppler and to narrow the gate. So I'm applying color Doppler, and currently you can actually see the pulsation of the umbilical artery. And then the next thing is to just adjust the color velocity. So if I do this, you can see at this point I'm having all manners of colors and even some aliasing. But when I adjust it a little, I have a clear picture. Remember that blue doesn't necessarily, it's not about artery or veins, it's about the direction of flow. And then I try to apply my gates, the gates, to feel the vessel wall as much as I can. I have this very active baby, so I'll try to take this waveform quickly. Okay, so you notice that there's a lot of movement. I have a lot of movement from this beautiful baby, so it's okay. Sometimes you may have those movements, fetal movements. It's okay to just go out and get a new alignment and start again. So preferably, if it's possible, I see we have a lot of fetal movement. If it's possible sometimes to even avoid vessels that are in between the limbs, sometimes it's very helpful. So I go out and then I'm coming cephalad now to see if I can see a free loop cephalad where I have less fetal movement. So this is around the fetal neck. I'm hoping that I should be able to get a good image here. So again, I'm adjusting the color scale. So quickly trying to. So you notice that just quickly that we have not the best of images, but we have the umbilical artery waveform demonstrated. And if we look below, we could see this is the umbilical vein. You could easily say you want to flip this image over, but ESWOG on the ESWOG guidelines, they actually say just take the waveform the way it is. I'm not going to make any attempts at measurement or making comments on that because I'm sure Dr. Higa will talk about that. So one more time, I want to try to zoom in. This is my area of interest, region of interest. I I try to zoom in. You see, this is where color flow comes in handy because it helps me identify the vessels. And then now my gate size seems appropriate. I could use any of this. Okay, let me reduce the size of the gate a little. Let me see what effect it would have. No, this is not a good image. I'm sure the baby knows we're trying to check, so.
All right, Shile.
All right. So, well, basically, we've been able to get our image. This is the initial image we had gotten. And I'm sure that if we were to have some measurements, we'll be able to, I'm just changing the baseline so we can make our adjustments. So thank you very much. I hope that we'll be able to demonstrate this very well. So thank you so much.
Thank you, sir. You can stop your image now, your sharing. Now, I want to say a big thank you to Dr. Shile. Not many people understand what has just happened. We've had meetings, some committees internationally, and they've been struggling to do something like this. So when he again introduced it, I said, let's work on it. I won't be surprised if some of my colleagues outside are on this because I have to tell them, I want you people to be here and see what we two are doing in Nigeria. Nigeria achieves a lot of things, but it's only the negative things that seem to be popularized. This is something that's great. We all know there are a lot of wonderful things that are coming out of our country, and we too must be proud of our country. So do a live demo is one of the most difficult things that you can do in COVID, in teaching. To teach people and say, yes, I'm going to do a live demo, it's extremely difficult. So for Shile to have done this for the whole world to see, it's something that's really great. Not that we can't give a standing ovation now because it's a web-based meeting, but I'm sure everybody is giving a standing ovation wherever they are. Of all the mentees I've had, I say that this is one of the ones that I always remember. He has done so well, and I feel extremely proud. They usually would say that for a good mentor, you are happy when even people that you have trained are doing better than you are. There are images he sends to me these days, and he wants me to help him interpret. And I'm wondering, if Shile cannot interpret it, you think I still can? So, it's something wonderful. I feel extremely proud of you, Shile. And I say, just keep doing the right things that you're doing. Now I'm going to start my own session. However, before I do that, I'll quickly just again share because I see that many more people have come in. I'm going to quickly share the slide of ISOG. ISOG is having its virtual congress. Also, before I start my lecture, I want to quickly just recognize a few of our colleagues who are with us. I want to recognize Professor Ikpeze from Unewi. He's the second vice president of Sogon. Welcome you, sir. And once again, my own chairman, Dr. Mojid Momo MNI, and also the president of Sahon Nabule. They were with us last week, and I'm glad that he's still here. And many, many, many other colleagues who have made sure that they are here every week. Dr. Janet from Ibadan, Dr. Ezenkwele from Enugu, Dr. Nicole from Abuja, and many, many, many others I can't easily mention the names now. We want to say that we are really glad that you are all with us, and we hope that we all continue to make the best of the session. So permit me now to quickly now start to show my slide. I'm sorry, I think where's my slide now? Yeah. So please just give me a minute. I think I've opened too many things, so it's becoming a bit difficult now. Okay, just a minute. Let me quickly close some of the slides that I have out. If I don't close them, then it will be difficult to get this open. Some of the slides have shut themselves down, so it's a bit tough. I'm sorry. Um, okay, I expect that it should show now. Okay, good. Okay, so I'll be talking about fetal Doppler velocimetry. I know we have a mixed audience. Not every person would have seen Dopplers being done previously. However, we'll try to make it very simple. About 2 or 3 weeks ago, I've given the early part of this lecture, and I'm going to repeat that early part, and then I'll move on to give the theoretical basis for some of the things that we do in Dopplers, and then give some examples. And then after that, we're going to leave the next half for about 2 or 3 weeks time, when we're going to actually look at clinical scenarios and how Dopplers have helped us in the management. So what are the learning objectives today? We expect that we should be able to understand the concepts of fetal Dopplers, know the commonly used Dopplers, and then many other things as already listed. Now, sometimes people complain and say, how come we are not having good Dopplers in our country and all that? And I want to tell people that some of these things don't come cheap. This is an example of a Doppler maternal imaging course from myself. That it's an online-based training program, so we can all book up. You just check the website. This is the cost for hosting, 500 euros. That's, I think it's a day or maximum 2 days. So that gives us an idea of how expensive some of these things are. So we know that not many of our folks can afford these, and it's based on that that we are putting in effort to make sure that we have this webinar for people to learn a lot from. So what is Doppler? Dr. has kindly given us ideas about Doppler, but let's just know that it's a non-invasive method of assessing the hemodynamics of the fetus. It has been shown to be important in fetal surveillance. So what essentially does it do? If we remember the short clip that he showed, what it does is that it measures the flow velocity of the baby during the cardiac cycle. So if we remember the cardiac cycle very well, you have the systole and the diastole. And if we remember our physiology, there's forward flow in systole, and then in diastole, there may be forward flow, but it's at a much lower velocity than the systole. So it is this flow, the changing flows, that Doppler velocimetry of the fetus measures. What is it able to do? Certain Dopplers are able to detect the presence of blood flow. Therefore, if you suspect that a fetus has died, one of the ways you confirm is to just apply Dopplers. And if there's no blood flow, you know that likely the fetus has died. Sometimes, if you are not sure, if you don't see the heart beating, all you just need to do is to put on the blood flow, and then you'll be able to see that actually there is blood flow in the baby, so the baby may not be dead. Another thing you can also see is the direction of flow, which he also showed to us. We will see that as we move on. Turbulence is something else I will see. I will show a clip on turbulence. You can actually measure the blood flow velocity. And then you can also use Dopplers to confirm certain fetal structures. Examples of this we're going to see shortly. This is an example of a clip. This is Doppler. With this Doppler, for those who know the anatomy of this area, this is the fetal, the vesical artery or the umbilical artery. There are two umbilical arteries and an umbilical vein. So once you see these two converging at the lower part of the fetus, you know that the structure that they surround is invariably the fetal bladder. So based on this, you can actually make a diagnosis, because in certain instances, we have seen situations whereby people are not sure what is in there, and then they see a cyst and they send it to you. Once you apply this, you are able to tell that this is the bladder. So it has great utility. This also was a slide I showed the last time, kindly donated to us by Dr. Owole from Ife. And then with this, if you know the anatomy of this area, this is the abdomen. The inferior, the descending aorta, alongside it, you have the inferior vena cava. So they give off the vessels, the renal vessels. So you can see only to one side, there's none to the other side. So with this, you can actually make a diagnosis of a unilateral kidney and a unilaterally absent kidney. So you can see, you can actually identify structures with the use of Dopplers. Remember, I also mentioned that you can see turbulence. So especially in gynae, for those who are involved in ovarian masses and the others, occasionally you can actually tell whether there is vessel. You can also tell about turbulence. Even in the fetus too, you can tell about turbulence, especially in fetal echocardiography. When you see turbulence, you can tell that the blood flow is not very good. And based on that, you can make certain diagnosis of some either constriction or some regurgitation in some way. That's why you can see that specific diagnosis can be made based on Dopplers. So what are the types of Dopplers that we have? The Doppler flow modes. There's the color Doppler flow mode. This has a great deal of utility in gynecology, and I will show you why. Then there is the, this is the color Doppler, which we've been seeing already. It has colors, specific colors, usually two major colors. Then we have the power Doppler, which is of more use in gynae because it has a single color and is able to detect very low flow. The color Doppler, if you adjust just like Chile did, you may be able to see low flows, but color Dopplers are able to identify higher flows as well. But power Dopplers can identify high flows, but it can also go as low as identifying very little flow, very slow flowing vessels, and that's important in some cancers. Then you have the pulse wave Dopplers. All these we are going to show as we move on. So this is an example of a Doppler trace. So we can see here that there are a lot of vessels. So we can identify vessels. And again, when you look here, this is like what tells you in which direction the blood is flowing. So if you see red, it therefore means that the blood is flowing towards the probe. And if you see blue, it means that the blood is flowing away from the probe. So all this blue shows, so it doesn't tell us whether it's artery or vein, it just tells us that this blood here, the blood flow in this one is flowing away from the probe, while all these ones that are red, they are flowing towards the probe. So it's important. Now, when you see all this transition is also what is called aliasing. This may not mean turbulence. What it just means is that what we have done is that we have not raised the PRF high enough. As I said, I'm going to make it very simple. So I won't go into the definitions of what those terms are, but essentially what this just means is that there's a mixture of the flow, velocity of the flow. There's slow flowing, there's fast flowing. So if you raise the PRF, what you now do is that you eliminate the low flowing and you get only the high flowing. And based on that, most of the high flowing will be forward flows on this area. And so you now see a very clean reddish flow. The same thing with the bluish flow. So it's important to get to know some of these things. Now, this is an example. So what we just showed to you, the last one, this is color Doppler. So it has two major colors. So that's an example of color Doppler. Now for this is power Doppler. Now how do we know it's power Doppler? It is single color and it's able to identify, as we said, very low flows, very low velocity flows. So that's the advantage. Now if you look at the map here, you see that it only has only one color. So that tells you that this is power Doppler. Now just to note that even with the color Doppler, you can adjust the colors. Yeah, so if you remember, Shirley talked about inverting. You could have just inverted it, and the one that was going down will now show as the one that's coming up. So you need to always look at the map to determine whether the color flow is towards the probe or away from the probe. Now we talked about power Doppler and color Doppler. The other one is the pulse wave Doppler. Pulse wave Doppler refers to this kind, not the not the trace that is below. However, it shows what you eventually have is a line and then a gate. This is a gate here, and then over vessels. So this is example of a pulse wave Doppler. And when you apply pulse wave Doppler, you now start to hear the sound, the fetal, especially for the fetuses, you can actually hear the fetal flow, the fetal heart rate apparently, and you can use it to count the heart rate. So once you have that, you see specifically, you know that this is the pulse wave Doppler. And when you now you can now click on your machine, and based on that, you can now get what is referred to as the sonogram. This sonogram is now a trace of the changing velocity. So the higher it is, the higher the velocity, and the lower it is, the lower the velocity. So on this particular one now, this particular trace from here to here is one cardiac cycle. This is systole, and then this is diastole. It is understanding of this that now gives us all the various indices for our assessment, which we are going to talk about very shortly. Though I can't hear your comments, but I hope I'm slow enough for people to follow. So as I said, this is the pulse wave Doppler. So towards the end of the last slide, I mentioned the fact that there's what is referred to as the sonogram. So the sonogram refers to this area. So I'm going to define the sonogram now. The sonogram provides a measure of the changing velocity throughout the cardiac cycle. So remember I showed you the cardiac cycle. So you could see the velocity was climbing, got to its peak, came down during diastole, got to the nadir, then it climbed again. So that whenever you see that, that is referred to as the sonogram. And in that sample volume, it tells you about the distribution of the velocity. So this again is a graphical representation of the sonogram. So from here to here is a cardiac cycle. From here to about here is systolic. From here to the end is diastolic. Therefore, it tells us that there's greater velocity during systole and less velocity of blood flow during diastole. So I hope this is simple. This is just a simple aspect of what Doppler does. So it is understanding of all this that you now use in assessing the indices that will help you to make a diagnosis of fetal distress or not. So the major indices, I'll just mention them now in case we don't mention them again, because I said we may not be able to follow everything. However, the major indices that we have are the pulsatility index, the resistive index, and the systolic diastolic ratio, and then the fourth one is the peak systolic velocity. So those are the four major indices that we use. So when sometimes we see people sending us 10 indices because the machine gave them 10 indices, they aren't really necessary. And so they confuse the uninitiated who does not know much about how to interpret the fetal Dopplers. So what are the common obstetric Dopplers? There are four commonly used obstetric Dopplers. You have the uterine artery Dopplers, the umbilical artery Doppler, the middle cerebral artery Doppler, and then the ductus venosus, in that order. So the commonly used indices I have already talked about. So why do we use these four Doppler measurements? For the assessment, there are different aspects of the fetal blood flow that are being assessed. And we need to also understand that because that's important. So uterine artery helps to assess the utero-placenta flow. I'm going to show a diagram to help explain this. While the umbilical artery will assess the fetal-placenta circulation, then the fetal hemodynamics by the middle cerebral artery Doppler and the ductus venosus Doppler. So I've already talked about this. These are the common Dopplers that we do. So let's explain them. The first one we say is the uterine artery Doppler. Uterine artery Doppler helps to tell us about the flow between the mother and, let's say, the uterus or even the placenta. So let's call it the utero-placenta flow. So between the uterus and the placenta. That's what the uterine, so the uterine artery, this uterine artery So the Doppler of the uterine artery tells us about the flow between the mother and the placental bed. It doesn't tell us much about the baby, but just the flow between the mother and placental bed. So if there is resistance, as you could have in preeclampsia, you could have abnormality of the uterine artery flow. And so that can be picked up early to say, this baby may be at risk of certain fetal conditions, including fetal distress much later. So that's for the uterine artery. After the uterine artery, so the uterine artery assesses the flow between the mother and the placenta. Now, after blood has gotten to the placenta, from the placenta, you also have blood flow to the baby. So the next Doppler is the umbilical artery Doppler. That assesses the flow between the placenta and the baby. It doesn't tell us what is happening inside the baby, but it tells us about the flow between the placenta and the baby. However, we know that if there is problem between the placenta and the baby, it may manifest inside the baby. But it is not the same thing as when there's a problem here, there must be a problem in the baby. Not exactly so, but it tells us that there's a high chance that there may be a problem in the baby. Therefore, if you now want to find how is the baby coping with this problem, so first of all, you have to identify that there's a problem here first. How is the baby coping with that? We now have to do the middle cerebral artery, which supplies the head, and then the ductus venosus, which tells us about the heart, how the heart is coping with the problems that the baby is having with the blood flow. And that's why at the last session, I gave this comparison and I asked, which is most important in economics? So let's look at it. This real life in COVID, we've been hearing about all this in Nigeria. There's a poor economic forecast. Oh, the gross domestic product has reduced, oil is not selling well in the market, and all that. Then they also tell us there's decreased foreign reserve, all the grammar that they keep telling us in the television. However, the one that concerns me is my bank account, my food at home, and then if my children and myself are well fed. These two are just like the uterine artery. The uterine artery, when there's poor economic forecast, it has a chance of hitting you. But we do know that poor economic forecast does not mean that you have no food at home. It only says that there's increased risk of you having reduced bank account and reduced food at home. The same thing with Nigeria's reduced foreign reserve. It may just mean that prices will go up. However, so these are the uterine artery Dopplers. Then this is now like the umbilical artery Doppler. So you go to your bank account, you find that the money is greatly reduced. So that's the same thing with the umbilical artery Doppler. It now tells us, the problem is no longer just economic forecast, so it's already reaching you. However, we also know that that doesn't mean that there will be no food in my house. It doesn't also mean that my children will be malnourished. So that, but however, it tells me that there could be an increased chance of these last two occurring. So how do I now know that the economic forecast has touched me? If I suddenly go home and I say, let me have my meal, they say, oh, I'm sorry, there's no food in the house. You know it has reached you. The same thing with malnutrition. If there's so that's essentially what it does. So umbilical artery Doppler tells us that bank accounts has reduced, the reserve has reduced. However, it does not mean that you are already being heavily affected. So we must understand these things. So we don't say abnormal uterine artery Doppler, fetal distress. Neither do we say that umbilical artery Doppler that's abnormal is equivalent to fetal distress. However, it tells us that it has set a high stage for fetal distress. So let's just quickly look at some of the vessels as we try to round off quickly. So the uterine artery Doppler, as we said, assesses flow to the placenta. It assesses the uteroplacental flow. Therefore, what do we use it for? We use it for screening. In preeclampsia, we know that there's increased resistance to flow between the mother and the placenta. So we can use it to screen. It's just a screening tool. It doesn't tell us exactly that there is. However, it tells us that there's increased risk that there may be increased resistance to flow to the mother. And what do we use? This is an example of a uterine artery Doppler. What we use, this is just a qualitative aspect, whereby if you see the early diastolic notch, it tells us that this is abnormal, and then there's increased chance that there may be increased resistance to uterine artery flow. Now, the umbilical artery Doppler, it is the commonest Doppler that we assess in fetal monitoring. As we've said, it assesses the fetal aspect of the placental circulation. And what it does is that it tells us the proportion of the chorionic vessels that are supplying the baby. As we all know, chorionic vessels supply the baby. So what this does then is that it assesses the proportion of these vessels that are supplying the fetus. So this is an example. They call it the sawtooth appearance. The saw, you know the tooth of the saw. So that's essentially what it is. So if you do it well, you see the arterial flow, and then you see the venous flow below it. So this is an example of a reversed uterine or umbilical artery flow, and this shows us that there's a problem with the flow to the baby. And in these cases, the chance is very high that also the other vessels showing hemodynamics of the baby will be abnormal as well. The next is the middle cerebral artery Doppler. What it does is that it assesses the fetal response to hypoxia. So essentially, we can always tell how the baby is faring. So the baby already has a setting for fetal hypoxia. So how does this baby cope with that fetal hypoxia? So that's what we measure with the middle cerebral artery Doppler. You need to know that the flow in the middle cerebral artery Doppler is different from the type of flow in the umbilical artery Doppler. In the middle cerebral artery Doppler, it has a very high systolic flow and a low diastolic flow. However, in the umbilical artery, you have both high and a relatively high diastolic flow as well. So they have different flow patterns, and it's good to understand these. So that's the major thing that you use the middle cerebral artery Doppler for. But there's also something else that is being used for, and is to measure the velocity, the blood flow velocity, and that has been shown to be a very good screening tool for fetal anemia. And one of the commonest causes of fetal anemia is rhesus negativity in the mother, rhesus X-ray immunization. So it's a good screening tool. So any woman who is rhesus negative merits to have a middle cerebral artery Doppler velocimetry and the measurement of the peak systolic velocity. So this is an example. So you can see tall peaked flow. So this is an example of the middle cerebral artery Doppler. So you can see it here. This is the this is the head, and then this is the mid. So this is the circle of Willis, and then this is the middle cerebral artery Doppler. So you have the one closer to the probe, you have the one away from the probe. And if you look over here, you can see that the red, based on the map, is flowing towards the probe. So the other obviously will be flowing to the other side, so it will be away from the probe. So all these are things, if you were to send your images for scoring, these are the things that are going to be checked. So we measured the 3 Dopplers already. The fourth one is the ductus venosus Doppler. It is a form of venous Doppler assessment. And what it does is to assess the heart compliance. So when all the others are abnormal and the baby is still remote from 10, you now wait and assess the ductus venosus Doppler. By the time this is becoming abnormal, you need to deliver the baby. It means that the baby is in imminent heart failure, and that can lead to fetal death. So it's important to have a good understanding of all this. This is an example of the ductus venosus Doppler. So what are the implications? I've already talked about the implication for the uterine artery Doppler, which we have said is important in screening for preeclampsia and IEGR, as we now know from basic physiology of the fetus, and even adroxio placenta. So By the time you are having absent end-diastolic flow, it means that close to 50% of the chorionic villi are no longer supplying the baby. So you can imagine that greater than 50% are no longer supplying the baby. And once it goes beyond that, you now have reversed end-diastolic flow. It tells us that the baby is at increased risk of fetal compromise. So when do we do Dopplers? Let us know that it is not every fetus that merits to have a Doppler evaluation. So it's mainly for high-risk pregnancies. However, we've seen in our country, at least we've just started doing Dopplers now. So virtually every baby that comes, we do Dopplers, but it's really not necessary. So it's been shown to be useful clinically in high-risk pregnancies. In any baby that has growth restriction, it's important to do a Doppler. Pregnancy-induced hypertension is important. Now, in multiple gestation, it's extremely important because you need to follow them up, especially in monochorionic twin gestation, which are at increased risk of twin-twin transmission syndrome. Then in rhesus isoimmunization, we've already mentioned that. And then in fetuses with congenital anomalies may become necessary and important for us to do that. Now, a big warning. In diabetes, it may give you false reassurance. So you must be very careful. In diabetes mellitus, you could have normal Doppler velocimetry, and the baby will still suffer in a few days sudden fetal demise. So you must be very, very, very careful in interpretation of Dopplers in the face of maternal diabetes mellitus. So when we need to use it, it should be indicated. And then the second thing is that you need to know the gestational age, just like Dr. Shile had mentioned at the very beginning. And when you are doing that, you want to look at the umbilical artery first. Now, looking at the uterine artery, especially in late gestation, may not be too necessary any longer because that's already telling you if there is a setting. However, the umbilical artery Doppler already tells you that this baby is going into some degree of compromise. And then the other features will now help us to determine what next we need to do. And if we have to conservatively manage, then the middle cerebral artery Doppler becomes important because it will tell us some issues of centralization. And if the baby is still preterm, we want to see if we can buy a little extra time before the baby eventually is delivered. So the baby does not come out alive but dies later because of extreme prematurity. So all these are important. Remember, I also said that in rhesus immunization, the middle cerebral artery Doppler is also of great importance. So there are ways in which this is done, and this is not a full lecture as we said, but if somebody already knows how to do it and does it, you should be able to interpret it. We've also talked about its use in multiple gestation. Now, there are other ways of monitoring the baby these days, and one of the common ones is the cardiotocography. But let us be aware that the changes in the Dopplers precede the changes in the CTG by at least 10 days. Therefore, the Dopplers are likely to have a better value in our assessment of our babies than the CTG, in that the CTG will tell us that, oh, the problems have already occurred, but the Dopplers can already tell you that the setting is there, and therefore you need to be very careful in the assessment of this baby. The same thing with the biophysical profile, which is much easier for us to do anyway. The changes in the Dopplers also predate the changes in the biophysical profile. So I think this will be a good area to stop for today's webinar. And then, as I said at the very beginning, in the next episode of Fetal Doppler Velocimetry, we're going to be looking at specific clinical case scenarios. We'll also look at some errors that have been made in our environment that we can learn from. And then we'll look at other aspects of Fetal Doppler Velocimetry. We also welcome feedback from all of us. I think I can stop sharing this slide now. We welcome feedback from every single one of us, and you can send messages to our website and also to our email address, which will be scrolled very soon. And at the same time, too, you can send a message to our phone by SMS. So I'm going to share this slide now. Unfortunately, we may not be able to take questions and comments, but I do hope that the lecture has made significant impact on, or at least it will make significant impact on our practice and training. And I hope too that every person would have learned greatly from what we have presented today. So thank you very much for your apt attention.